hyponatremia is one of the common endocrine emergencies which is encountered in pediatric practice. And this is one of those conditions which is quite important in terms of the overall clinical perspective and in terms of challenges in terms of diagnosis and management. This was a 14-year-old boy who presented with drowsiness, was clinically euvolemic, had a high urinary sodium and a high urinary osmolality. So we had a child who had a dilute blood and a concentrated urine and clinically was euvolemic. So this is a classical feature of SIADH, was advised fluid restriction in the terms of diagnosis of SIADH. But unfortunately, the child had a sudden worsening in seizures which developed. Now, this is a very, very common mistake which we encounter in pediatric endocrine practice, is that any euvolemic hyponatremia is often considered as SIADH and advised food restriction. When we'll discuss subsequently that SIADH is essentially a diagnosis of exclusion, and we have to exclude FT4 and cortisol deficiency before we label somebody as SIADH. Now, when the endocrine team was called here, we found that this child actually had a very low level of thyroid and cortisol, turned out to be a multiple pituitary hormone deficiency. So this is one condition which clearly illustrates that there is a need for comprehensive evaluation before we make a particular diagnosis in that setting in that regards. We had the 16-year-old girl with abdominal pain who had recurrent episodes of pain and again developed seizures during admission. This time she had hyponatremia, was euvolemic, and was clinically fitting into SIADH. So this was pretty clear that this is SIADH, but your diagnosis does not end there. You have to look at a cause. So this child had been managed as SIADH on a couple of occasions, but this time when we were called, we were able to identify that there was a common feature of a recurrent abdominal pain in that girl, and that led to the diagnosis of essentially of porphyria, and that was causing the SIADH. So there is challenges which are there with regards to the evaluation as well as the management in that perspective, and we need to be very careful about in that regards. Now, if we go carry forward from here, so this is the PG lecture series that we are continuing. This is the 6th talk in the series, and today we will talk about hyponatremia, starting from pathophysiology, criteria, management, and then we'll finally take question and answers in that perspective. So all of you can go and have a look at our website, learning.growsociety.in, which covers a wide variety of aspects of pediatric endocrine resources, provides opportunity to learn. There is also a YouTube channel, which this is being streamed right now, and you can have access to a large number of videos which are available on various aspects of pediatric endocrinology. Our courses, which provide validated tools for pediatric endocrinology learning and practical assessment in that regards. And then we have got courses like fellowship course and the postgraduate course, which is available for access in that setting. We do conduct 3 different types of grant rounds. One is that for the endocrine trainees, one for the general pediatricians, and this the PG lecture series in which we have covered growth, and now we are moving towards electrolytes in that regard. This happened once a month in that scenario. We have got publications which cover the entirety of pediatric endocrinology from basic to advanced, and our mobile application helps to diagnose and assess and manage these conditions. And we are going to launch today, as I speak, the next version of mobile app, which will provide much easier interpretation of a wide variety of conditions. Now, hyponatremia, as we have discussed, is a very challenging condition, a condition which is associated with significant effects, acute effects, and long-term effects. So an understanding of pathophysiology becomes extremely important before we discuss about etiology and approach in that perspective. So when we talk about hyponatremia, why is sodium so important? So normally we talk about osmoles, and we talk about 3 major osmoles: sodium, glucose, and urea. Now, what we need to understand that out of these, sodium and glucose cannot cross the cell membrane. Urea can freely cross the cell membrane. So while from a osmolar, a primary biochemical perspective, all 3 are osmoles, sodium and glucose are the ones which decide the tone of the blood. So they are the major determinant of the tone of the plasma. And out of it, since glucose is normal unless somebody has hyperglycemia, sodium is the key determinant of the tone, and this decides whether the fluid comes in or goes out from the cells, and therefore sodium is very, very important. Even mildest changes in sodium will cause cell swelling or will cause cell shrinkage, and that is why sodium is one of the most tightly regulated, and I would say the most tightly regulated overall metabolite across board. If you talk about glucose, if you talk about calcium, they have a margin of error of around 10 to 20%. Sodium and osmolality have a margin of error of 1%. So if your serum sodium goes above 145, the body immediately starts to act. And that's why we need to know a lot about sodium and why it becomes important. Now, AVP is a predominant regulator as far as volume. And when I talk about serum sodium, we need to understand that serum sodium is determined by two major factors: the total amount of sodium and the volume. So the volume is the major determinant of sodium in that regards. And if your fluid is less or more, you will have hypernatremia or hyponatremia. Now, conditions associated with increased level of AVP, you will have decreased tone in the blood, and therefore the fluid will basically go into the cells because it has got more concentration. The cells will swell up, and that will cause features of irritability, headache, vomiting, those perspective, and ultimately they will try to extrude the osmoles, and that's why they will try to maintain it. Now, when we give them a particular treatment and there is a rapid change in sodium, there would be a sudden shrinkage resulting in myelolysis. So hyponatremia presents with cell swelling, and acute treatment will cause sudden disruption of the cells, causing myelolysis, and we need to be very cautious in that perspective. Now, this is what I was talking about. There are two major determinants of the overall sodium status: the tonicity, how much sodium you have, and the volume. Now, the major determinant of serum sodium is actually volume. And when we are looking of causes of hyponatremia, which are focusing today, we are mainly talking about problems which are associated with increased free water rather than a problem of loss of sodium. And when we talk about in the next session about hypernatremia, that is again because of deficiency of free water rather than sodium excess. So most sodium disorders are problems of fluid volume status and rather than a sodium status in that perspective. Now, we all know there are two mechanisms which maintain the volume. One is the thirst, how much water we take. And this is a major defense against hypernatremia. So if you're developing hypernatremia, you will drink more water and compensate. The other is urine output. So urine output is a major defense against hyponatremia. So if somebody is having a lot of free fluid, there will be an impairment of the AVP effect, and you will have aquaresis in that perspective. So urine output is the major defense against hyponatremia. And in a corollary, if you think of it, decreased urine output or increased urinary concentration, which is inappropriate for sodium level, quote unquote SIADH, is associated with hyponatremia. Now, what we need to understand is that ultimately, if we talk about chronic hyponatremia, anybody who has a chronic hyponatremia should have a AVP excess. And that is very, very important to understand in that perspective. So as we discussed, if your tonicity increase, the brain finds a signal that, okay, we need to shed the amount of that. We need to basically have more water. Your AVP starts coming in, and that really starts to really conserve the free water in that perspective. Now, if your volume goes down, now major regulator of volume is actually sodium. Now, this is also interesting. So when your volume status is not to do with free water, but with sodium. So if your volume goes down, the renin, angiotensin, aldosterone system starts to get activated. And what it does basically is that it is conserving sodium. But while it is conserving sodium, it is causing a loss of potassium. So conditions associated with defects in the renin, angiotensin, aldosterone system, be it hyporeninism, aldosterone deficiency, pseudohypoaldosteronism, all these conditions will be associated with fall in sodium, but again in proton and potassium, because that's how your exchange happens. So they present with hyponatremia, hyperkalemia, and metabolic acidosis in that regards. Now, if your volume becomes too much, there is a third player which will come up in the picture, which is the atrial natriuretic peptide, which will cause loss of sodium. Now, this is very important in the setting of a SIADH state. So syndrome of inappropriate AVP secretion is essentially a hypervolemic state. Now, because of that, the ANP becomes active and it causes loss of sodium. Therefore, the volume then becomes euvolemic and your sodium levels go down. So the cause of hyponatremia in SIADH is not only dilutional, it's actually sodium loss. What does it mean? It means that if you push them normal saline, you will cause immediate natriuresis because ANP is there, aldosterone levels are low, the body wants to shed all the sodium. So giving sodium chloride will be of limited role in that perspective, and that is something which is very, very important from that regards. So what we need to understand from this perspective is that the major cause of sodium imbalances are actually problems of water and not sodium. If you have too much water, you will have hyponatremia. If you have too little water, you will have hypernatremia. Absolute losses of sodium are rare. They may happen like gastrointestinal loss, very, very rare, or urinary loss in the form of diuretics, in the form of salt wasting crisis. But even there is an increase in AVP. Because all of these conditions cause hypovolemia, and your AVP also is triggered via hypovolemia, and that really causes a further worsening of hyponatremia. So for anybody to have persistent hyponatremia, your AVP excess is important. This may be inappropriate in the setting of SIADH or appropriate in the setting of hypovolemia because of third space loss, because of adrenal insufficiency, diuretic use, or whatever in that regards. Similarly, and we'll talk about potassium later on, to have persistent hypokalemia, you need to have high aldosterone, which may be primary or secondary. So anybody who has a chronic hyponatremia, AVP has to be high. Anybody with chronic hypokalemia, aldosterone will always be high. Both of them can be appropriate or inappropriate. That's a different thing altogether in that regards. Now, most sodium that is filtered via the proximal tubule is absorbed right there, around 97%, and only 2% is basically absorbed at the collecting duct. But this is what is most important. This is the hormonally regulated sodium absorption. This is done via the epithelial sodium chloride channel, which exchanges sodium along with chloride. Now, this is where aldosterone acts. So all that we're talking about today is largely at this point 2%, 97% is already absorbed here. Now, this epithelial sodium chloride channel will cause movement of sodium and chloride, and you will say, okay, this is a neutral compound, so why should they will be exchanged with potassium? The reason for that is sodium is brisk. It goes off just like that, while chloride comes out slowly. So the lumen, the tubular lumen, becomes electronegative. And because of that, it then attracts positive compounds like proton, potassium, magnesium, calcium. These will be less, but proton and potassium are most important. So therefore, anybody who has hyponatremia, anybody who has got a decreased effect of aldosterone action, anybody who has got less delivery of sodium in this region, will not have enough sodium to exchange with potassium and proton. So whenever you have a RAST effect, you will have hyponatremia. Along with that, you will have potassium retention causing hyperkalemia and proton retention causing metabolic acidosis. So that's the classical picture of RAST effect. Now, the whole pathway which regulates this is the renin-angiotensin-aldosterone pathway. Renin is triggered via potassium excess and volume depletion. It then converts angiotensinogen to angiotensin 1, which is converted via the peripherally via the angiotensin converting enzyme to the angiotensin 2, which is very, very important in regulating both sodium and volume. Now, AN2 is going to have a direct effect on the blood pressure by causing vasoconstriction. It is also going to stimulate thirst, and it is going to produce aldosterone more. So it is a very interesting phenomenon. Your volume goes less. Your body senses that you need to increase your pressure, you need to increase your volume, and you need to increase your sodium. So just by using angiotensin 2, it is causing vasoconstriction on one point, increasing thirst, so volume goes up, and increasing aldosterone, increasing your sodium content. So this is the wonder as far as the RAS axis. It from one aspect, it has a multitude of effects which are there in that perspective. Now, ACTH and vasopressin have some permissive effect on aldosterone secretion, but the major regulator of aldosterone is actually at the level of volume and the renin system and not ACTH. This is very, very relevant in, and this is what Dr. Pratik will talk about in the setting of central cortisol deficiency or ACTH deficiency. So in ACTH deficiency, you will have hyponatremia, but that hyponatremia will not be severe because you do not have a mineralocorticoid problem. Even if you have zero ACTH, the renin will control your aldosterone and your hyponatremia will not be severe. But if you have a combined glucocorticoid and mineralocorticoid deficiency, you will have severe hyponatremia. On the other hand, if you have an isolated defect of the aldosterone, you will have hyponatremia, but there is no concomitant cortisol deficiency. Remember that cortisol inhibits vasopressin. So if you have cortisol deficiency or ABP will go up further, you will have worsening of hyponatremia. So the worst condition associated with hyponatremia and hyperkalemia is primary adrenal insufficiency. Both cortisol as well as aldosterone is affected. If you have ACTH deficiency or ACTH resistance, you will only have hyponatremia. Your potassium will be normal and your sodium will be marginally deranged. So very importantly, you do not need to have hyperkalemia with hyponatremia to have adrenal insufficiency. That is true for primary adrenal insufficiency. In secondary adrenal insufficiency, you will just have hyponatremia. While the third picture of aldosterone deficiency or resistance will have severe hyperkalemia as a major feature, while hyponatremia will be milder around 120, 125 in that perspective. Now, ANP, of course, will cause natriuresis. So in somebody whose volume is more, like free space loss, cardiac failure, nephrotic syndrome, cirrhosis, or you have SIADH, ANP will cause further sodium loss and you will have hyponatremia in that perspective. So importantly, cortisol has an effect also at the aldosterone receptor, which is more relevant from a different perspective and therapeutic perspective in that regards. Now, this is also very important. If you have too much free water, like in the setting of a third space collection or in the setting of SIADH, the AVP secretion will go down. It will allow the urine to pass the water. And that's what I said, that the major defense against hyponatremia is urine output. The major defense against hyponatremia is thirst. The major defense against hyponatremia is the urine output. So if your fluid is too much, pass it in the urine. That's why the AVP goes down. So normally anybody who has got excess free water should have a urinary sodium less than 25 or a urinary osmolality less than 100. If, however, your urinary osmolality is more than 100, this is inappropriate. Dilute blood and concentrated urine, this is SIADH. Concentrated blood and dilute urine, that is diabetes insipidus. That's something which is important to understand. So now if we look at hyponatremia, it can either be because of too much free water. This may be because of third space collection like cardiac failure, nephrotic syndrome, or chronic liver disease, because of SIADH. It may also be because of endocrine deficiency. Now, these conditions will have hypervolemia. Along with hypervolemia, they will have hemodilution. So the hemoglobin will go down. And very importantly, if your volume goes up, in that scenario, you will clearly have a decline in uric acid, because uric acid excretion is dependent upon the volume. If your volume is more, you will lose more uric acid and uric acid levels become less. If your volume is less, you will lose less uric acid and uric acid level will go up. So uric acid is the best marker of volume status. And if you are confused between a low volume state like cerebral salt wasting versus a high volume state like SIADH, do a uric acid. If uric acid is low, this will favor a fluid volume more, that is SIADH. If uric acid is high, this will favor more in the setting of a cerebral salt wasting. And we'll discuss this in more detail in that perspective. You can have sodium loss, but I said major cause is free water excess. Sodium loss can be because of RAS defect. renin deficiency, aldosterone deficiency, aldosterone resistance, or tubulopathies. Now, interestingly, RAS defect will be associated with hyponatremia and hyperkalemia. As we'll discuss subsequently, we'll understand that usually electrolytes go opposite. If your sodium is high, potassium goes low. If your sodium is low, potassium goes up. So that's typical of RAS defect. But if you have a diuretic use or a GI loss, you will have both hyponatremia and hypokalemia. But Dr. Linda is talking about what is about a case of very low sodium and normal potassium. This is an unusual scenario, and generally speaking, I have seen a couple of cases with severe MPHD who can present like that. Sometimes you can have severe SIADH because of a nephrogenic SIADH which can cause, but this is an unusual scenario. If you talk about sodium levels less than 110 or 120, that will be unusual. Usually 120 is okay. Less than 115, that becomes difficult. Dr. Rajiv Das is asking what would be the initial food in a 6-year-old child with body weight 20 kg admitted involved with Japanese encephalitis so that hyponatremia can be prevented. So generally, more people are more talking about in terms of more fluids which is appropriate, more physiological rather than the hypoosmolar foods. So Dr. Pratik, what will be your take on somebody who has a JE?
Sir, initially we are at a risk of developing hyponatremia. So more than the fluid, it is the regular monitoring of the fluid which we should do. Of course, normal saline we can see whether how the sodium is dropping or rising more than exact fluid we are giving.
Generally, we should look at the maintenance fluid, whatever is recommended for anybody else. There is no routine recommendation to restrict fluids in that setting or to really look at different fluids. You monitor the sodium, that is more important because it may not develop in many cases. You will have normal, and then giving less fluid may be a problematic scenario. Dr. Rajiv is also asking about volume status in kwashiorkor. That's again an interesting scenario. So then uric acid may be a role in that perspective that will give you a picture in that regards. It will behave more like a fluid third space loss scenario. So more like a CCF or a liver disease or nephrotic syndrome. Dr. Ashubu is asking when looking at rate of fall, what should be the interval between the requests? So generally speaking, that will depend upon the severity. I would say 3 to 4 hourly will be reasonable in that regards. If you're giving an infusion, then you have to be more careful, but 3 to 4 hourly is good enough. Dr. Subhash is asking low sodium, low potassium. The most common cause I would say would be diuretic use. That's what we encounter less in children, more in adults, but that's the most important cause. Rarely diarrhea with inappropriate ORS will be the second scenario. The third would of course be tubulopathies, but diuretic use number one would be that in that scenario.